Hi everyone, my name is Rachel Booth and I will be presenting a palliative care business proposal, the Palliative Care Discharge. Palliative care services are important for all patient populations because they focus on symptom management, which includes pain, nausea, dyspnea, as well as emotional and spiritual support. Palliative services also focus on patient and family goals of treatment and can serve as an excellent partnership between all realms of healthcare. A coordinated care system is essential because no longer is the primary care provider the only practitioner involved, especially for the typical palliative care patient who has chronic and/or comorbid conditions and has several practitioners involved in their care. Care can easily become fragmented and communication can be broken between practitioners and patients. In current times, hospitalists are assuming care upon admission and discharging patients without the ability to follow up, creating a disconnect. One study found that only 3% of primary care providers were involved in the hospital discharge planning process. I am proposing the implementation of a follow-up phone call 24 to 72 hours after discharge for patients who have received a palliative care consult during their hospital admission at Meriter Hospital. Why 24 to 72 hours? A study done by Kumal found that the hospital environment can make it very difficult to assess a patient's palliative care needs. Physical and psychosocial distress leading to symptom exacerbation can be increased in the home setting. For this reason, once a patient is returned to their natural environment, it is important to reassess their status and provide further intervention as needed. This is truly integrating palliative services into the patient's care. My primary goal is to improve the coordination of care, including communication of care plans between inpatient and outpatient services for Meriter patients who have received a palliative care consult during admission. Two of my main objectives are to decrease the number of readmissions within 30 days for palliative care patients with uncontrolled symptoms by 30% within 3 months of the follow-up phone call implementation. Also, to decrease the number of ER visits within 30 days of discharge by 30% for palliative care patients with uncontrolled symptoms within 3 months of the follow-up phone call implementation. And why 30 days? Medicare readmission data is based on 30 days readmission, and for that reason this data is already being collected, so it would be a good place to start. My two primary outcomes are to reduce symptom management related readmissions and ER visits for palliative care patients. Also, improved adherence to palliative symptom management plans for patients transitioning to the outpatient care. I plan to start with a pilot study using a specific patient population for ease of data collection and efficiency of evaluation. Patients with a cancer diagnosis have been found to be a large percentage of those requiring palliative services. Although current tracking abilities are limited, Meriter Hospital estimates that approximately 22%, that is 97 of the 446 consults for palliative care, were oncology patients, and this is 2013 data. I have chosen to focus on symptom management consults because they are at a higher risk for readmissions and ER visits after discharge. The Edmonton Symptom Assessment Scale will be used to determine those patients at high risk for readmissions and ER visits within 30 days of discharge. This is because this ESAS assessment is used upon initial consultation with the palliative care nurse practitioner at Meriter Hospital and can be used for the purposes of a follow-up phone call as well. The ESAS assessments tool is a well-established tool that is used to determine a patient's perception of their symptom burden. It is a valid and reliable tool. Any patient with 2 or more symptoms scoring a 1 or above are considered to be high risk and multi-system complex patients, according to the palliative care nurse practitioner at Meriter Hospital. They are therefore considered high risk for readmission and ER visits. Again, this tool can be conducted by first the palliative care nurse practitioner upon initial consultation, and then again during the follow-up phone call by an RN. As you can see, Meriter's mission statement states, to serve our patients for a lifetime of quality health care. Meriter does have a well-established palliative care program, but there are not yet services available for patients who are discharged into the community. Meriter's vision statement states that Meriter will be a fully integrated healthcare system. In order to provide quality, integrated care for throughout all life transitions, Meriter must consider the continuation of the palliative care services into the outpatient setting. Here I have conducted a SWOT analysis. Some of the strengths that I've identified is that the palliative care program has a close-knit group of members that are currently looking for areas to improve. Also, the organization is small, and therefore reaching out to patients will not be overwhelming and is entirely possible. Some weaknesses. Due to the organization size, for example, there are only 446 patients who were consulted by palliative care so far this year, the efficiency of the program will take some time to prove with data. Also, there is very little information that is tracked at the current time related to palliative care consultation. Much of the current data is based on hospital-wide information with very little specificity. Some opportunities. Because this is a quality improvement project, it does fit well with Meriter's vision to provide quality integrated care for all. And also, after my interview with the palliative care coordinator, I learned that Meriter is in the process of developing an outpatient palliative care program, so the timing is right. Some threats. It is possible that some physicians will be resistant to change. Oncologists and primary care providers may not be open to palliative care suggestions after discharge. Also, as the tracking system will be new, technology will need to be developed to accommodate the data collection needs, and this may also take some time. My operation plan. The facilities that will be used will be through Meriter Hospital, and there are currently offices for both the palliative care and hospitalist services, and so the space and utilities are already accounted for. For future considerations, when Meriter does complete its outpatient palliative care program, space and utilities will need reassessment because another staff member will likely need to be hired. Locations. The initial assessment and enrollment of the patient into the pilot studies will occur on the inpatient units at Meriter Hospital. Patients who are not accessible by phone for the follow-up will not be involved in the proposed pilot study, but will be tracked for data collection purposes. Operating costs. A computer, printer access, phone, pens, paper, Epic documentation access, and also statistical data analysis software will be needed for the project. Labor. The pilot study responsibilities will be divided by the hospitalist RN and the palliative care RN, as well as the palliative care nurse practitioner. All these positions are currently filled, and responsibilities for the pilot study will be rolled into their current roles. In the future, at least a part-time RN position will be required. because when the project is implemented hospital-wide, we will need to accommodate at least about 446 follow-up phone calls a year. Hopefully, when Meritor's outpatient palliative care program is fully developed, this position will evolve into a full-time case manager position. My implementation plan. Stakeholders will be involved in all aspects of planning due to the potential involvement of this project into Meritor's outpatient palliative care program. Some stakeholders that I hope to include are the palliative care team, consisting of the RN, social worker, and a nurse practitioner, the hospitalist team, including hospitalist representation and an RN, the oncology team, which consists of all physicians, primary care representative, I hope to recruit up to 2 members, a local hospice representative, a nursing education representative, and then also for consultation purposes, I hope to involve an informatics specialist as well as a member from another organization's palliative care team. As far as a marketing strategy goes, as I discussed in the SWOT analysis, physician resistance to change may be a barrier. Therefore, I plan to provide education regarding the current discharge process and new strategies to improve this process as well as communication, in hopes to alleviate the resistance. My pilot study timetable, I hope to implement the pilot study for approximately a 6-month period. I estimate there will be about 50 participants involved in the pilot study during this time period. I hope for daily coordination between the nurse practitioner and 2 of the RNs, the hospitalist RN and the palliative care RN. And I also hope to conduct evaluations every 3 months of the pilot study, but this depends on the new data collection systems and whether or not they were in place and able to measure outcomes. During the pilot study period, I hope to have monthly meetings with the entire stakeholder team for both evaluation and development planning. Responsibilities during the pilot study. The initial interview and ESAS assessment will be done by the palliative care nurse practitioner, as it is already her responsibility to do so. Follow-up phone calls for patients who are admitted by the hospitalist will be done by the hospitalist RN, which is already her responsibility, and those who are admitted by any other physician will be followed up by the palliative care. The financial plan I'm proposing for this project includes expected expenses, which the majority will come from meeting time and staff education, but also the data collection software that's going to be needed for this project. Revenue. Revenue is going to be very difficult to determine until the data collection software is improved. Currently, hospitalizations are classified by DRGs, and these patients are not yet hospice beneficiaries, and therefore certain tracking must be put into place. The tracking that I would like to monitor would be estimated cost and length of stay for palliative care patients, readmission rates for palliative care patients, ER visit rates for palliative care patients, as well as common DRGs for these patients. Several of these other features I've discussed in the operations plan, such as the personnel, tools, and supplies. Concerning the available money, Meritor is currently designing their outpatient palliative care program, and funds will exist through this program, so I'm hoping to jump on board with that. Services to be provided. The pilot study estimates about 50 patients will be serviced in a 6-month period. For the evaluation analysis, outcome measurement will focus on data collection and the satisfaction of the stakeholders with the improved communication process. Thanks for listening.